Welcome to the Deep Dive, the show where we take complex topics and really unpack them for you, giving you that shortcut to being truly well informed. Today, we're plunging into a topic that, well, at first glance, seems to hold a surprising paradox: safety in healthcare. Think about it, we entrust our health and the health of our loved ones to doctors and hospitals. The expectation is getting better, being healed. It's the ultimate act of faith, really. Yet sometimes the very system designed to help can inadvertently cause harm. It's a jarring thought, isn't it? Especially when we consider our most vulnerable patients, children.
It absolutely is a jarring thought. And look, it's a stark reality within healthcare. But to be really clear right from the start, this deep dive isn't about pointing fingers or, blaming individual healthcare providers. That's a common but ultimately unhelpful misconception. Instead, it's about understanding the inherent complexities of a massive, intricate system, a system where countless interactions, technologies, and, well, human elements all converge. Our goal today is to unravel that complexity, to move beyond the surface level and truly grasp the mechanisms of safety.
Right. And that's exactly why we're here. For this deep dive, we're focusing specifically on safety in healthcare for children, drawing from an authoritative medical text. It's a crucial area that honestly impacts every one of us, whether directly as a parent or caregiver, or indirectly just as a citizen.
And our ambition for you, the listener, is really to explore every single layer of this critical topic. We want you to master this information, to think like the elite professionals in this field. We're going to move from the fundamental definitions of what harm actually means in a clinical context, all the way to understanding the sophisticated frameworks and practical tools that professionals use daily to ensure the safety of our most vulnerable patients. We'll unpack the challenges and also the remarkable, sometimes unsung, progress being made. We're aiming for a level of mastery that connects all the dots for you.
And when we talk about harm, well, let's not shy away from some truly stark figures. The Harvard Medical Practice Study from back in 1991, which looked at adult hospitalizations in New York State, found adverse events in an estimated 3.7% of those cases. And here's the kicker: 13.6% of those adverse events tragically led to death. Fast forward a bit, and the National Academy of Medicine estimated that as many as 98,000 Americans die annually in hospitals just from medical errors. Just let that number sink in for a moment.
It's a difficult truth, yeah, but one we really need to acknowledge. Absolutely. And while those figures are primarily from adult healthcare, the reality is that children also face substantial healthcare related harm. The data is still maybe less robust compared to adults, but we know nationally hospitalized children experience approximately 1,700 central line associated bloodstream infections. We call those CLA BSIs, and about 84,000 adverse drug events each year. These are significant numbers for our pediatric population, reminding us that, well, no patient group is immune to these risks.
So why should you care about these numbers? Why does this deep dive matter to you personally? Because whether you're a parent entrusting your child to medical care, a caregiver for a loved one, or simply a citizen of a society that values the well-being of its children, understanding these risks, and maybe more importantly, the immense efforts underway to mitigate them, is profoundly empowering. This deep dive is for your enhanced understanding, to help you feel more informed and, frankly, more confident in navigating this complex world. And there's a real beacon of hope in this space. The Solutions for Patient Safety, or SBS, Collaborative. This incredible network includes over 145 children's hospitals across the U.S. and Canada, all working together as a learning network with one primary aim: to eliminate serious harm. This isn't just about identifying problems, it's about pioneering solutions and driving relentless progress.
Exactly. And it's important to expand on that holistic view. It's not just about patient safety, as critical as that is. It's also about the safety of the healthcare providers themselves. The provision of healthcare can be a dangerous profession. Injury rates, surprisingly, surpass even those of coal miners. When healthcare workers feel safe, when their well-being is prioritized, it directly impacts patient outcomes and helps prevent burnout, creating a more resilient and ultimately more effective care environment for everyone. We'll definitely connect those dots for you as we explore how these two aspects of safety are just so intricately linked.
When we talk about safety in healthcare, I often hear people use error and harm almost interchangeably.
Yeah.
But I suspect in your world, those are very distinct concepts, aren't they? And why does that distinction really matter for us, the listeners, to get our heads around?
Yeah, that's an excellent question. And yes, you're absolutely right. They are distinct, though obviously related. Understanding the differences, well, it's foundational to how we approach safety improvement. An error occurs when a member of the healthcare team either does the wrong thing, which we call an error of commission, or maybe less obviously, fails to do the right thing, an error of omission. Think of it as a deviation from what should have happened. Now, here's a critical challenge. Errors of omission, like failing to arrive at the correct diagnosis because maybe a key test wasn't ordered, they are considerably harder to measure and track than errors of commission. You can see how that immediately complicates the picture for folks trying to measure safety. Harm, on the other hand, is defined by the Institute for Healthcare Improvement, or IHI, as unintended physical injury resulting from or contributed to by medical care. And this includes the absence of indicated medical treatment that requires additional monitoring, treatment, or hospitalization, or that results in death. The crucial point here, and this is really key, is that most errors in healthcare actually do not lead to harm. An error might be caught, maybe by another team member or a system check, or it might simply not have severe enough consequences to qualify as harm under that definition. And harm itself can be categorized, importantly, as either preventable or non-preventable. That distinction is vital for determining where to focus our improvement efforts, right? Because you can only truly intervene on what's preventable.
Right. That distinction between error and harm, and then splitting harm into preventable and non-preventable, that really shifts your perspective, doesn't it? So to make it super concrete for you listening, let's walk through a clinical example. Maybe something like a simple medication order for a child.
Yeah, this example, drawn directly from our source material, perfectly illustrates the relationship. Let's say a physician erroneously orders an aminoglycoside antibiotic, but they miss a decimal point. So they order 25 millikilogram instead of the intended 2.5 milligram, a tenfold overdose, basically. Now, scenario 1. If this error is caught, maybe by a computerized order entry system that flags the dose as unusually high, or perhaps by a vigilant pharmacist reviewing the order before it's dispensed or administered, then it's an error, yes, but no harm results to the patient. This scenario is incredibly valuable. In patient safety, we call these near misses, and honestly, they are gold mines for learning. They reveal system vulnerabilities without the tragic outcome. It's almost like the system is waving a flag, telling you exactly where the hidden weaknesses are before someone gets hurt. That's the real power, isn't it? It completely flips the script on how we view mistakes.
Okay, so that's the near miss error, but no harm. What happens if it isn't caught?
Right, scenario 2. Imagine the same error. The physician orders 25 milligicograms instead of 2.5 milligicograms. If this error is not caught, and the patient receives that incorrect higher dose and subsequently suffers acute kidney injury, which is a known side effect of too much aminoglycoside, that would be classified as preventable harm. Why preventable? Because evidence shows that things like pharmacist review, a clear system-level intervention can reduce the risk of these types of errors tenfold. This clearly demonstrates how system design and having multiple checks in place can prevent actual harm. Now, contrast that with a different scenario. A patient receives their first ever dose of amoxicillin and unexpectedly has a severe anaphylactic reaction requiring hospital admission. This is undeniably harm, right? A severe allergic reaction. However, it's considered non-preventable harm. Why? Because currently there just aren't any valid predictive tests available for antibiotic allergies. The harm occurred, but it wasn't due to a system failure that could have been foreseen or prevented with our current medical knowledge and tools. Distinguishing these categories is so vital for focusing improvement efforts where they can actually make a difference, ensuring we're not, chasing unpreventable events, but really focusing our energy where it can yield results.
That example really drives home the point. Those almost errors, those near misses, they are vital learning moments. They're not just mistakes to be ignored or swept under the rug. They're real opportunities to reinforce the system, a critical component of learning.
Absolutely. And this leads us neatly into the concept of latent risk. This is the inherent potential for harm that exists within a system, independent of any immediate error. Think of it as hidden dangers or vulnerabilities built into processes, equipment, or even organizational culture. They're just waiting silently for the right sequence of events or maybe an active error to trigger actual harm. For instance, if two different IV lines look identical and can be accidentally connected, that's a latent risk, even if no one has made that specific mistake yet. And as we just discussed, near misses are those deviations that either don't reach the patient at all, or maybe high-risk situations that just don't lead to harm purely due to good fortune or some last-minute save. These are, as you said, gold mines. They provide invaluable data points, alerting us to potential system weaknesses or those latent risks before a patient is actually injured. Learning from these almost errors is really a cornerstone of proactive patient safety, allowing us to build stronger, more resilient systems.
So, given all these nuances, errors, harm, near misses, latent risks, how do professionals actually quantify and categorize harm across the board? What are the standard systems for measuring its severity and impact?
Yeah, there are several sophisticated classification systems used to rate harm severity. each serving a slightly different purpose. For medication-related harm specifically, there's the National Coordinating Council for Medication Error Reporting and Prevention, or NCCRRP index. It provides a standardized scale just for categorizing medication errors and their associated harm. More broadly, for all-cause harm, there are various general severity scales that healthcare organizations adopt to assess the impact of any adverse event. A particularly important category, especially for a collaborative like Solutions for Patient Safety that you mentioned, is serious safety events, or SSEs. These are defined as deviations from expected practice that lead to death or severe harm. The SPS Collaborative has the elimination of SSEs as its primary overarching goal because these really represent the most catastrophic failures of the system. Then you have sentinel events, or sometimes called never events. These are the catastrophic, highly visible events that should theoretically never happen in healthcare, things like wrong site surgery or leaving a foreign object inside a patient after surgery. These are prime targets for external reporting, often mandated by regulatory bodies like the Joint Commission, and they're the focus of intense quality improvement initiatives. They're seen as indicators of a profound system breakdown and usually trigger a very thorough investigation. And finally, there's an increasingly used metric called the Composite Serious Harm Index. This is a really powerful tool. It combines a variety of preventable healthcare-associated conditions, or HACs, like the CLA-BSIs we mentioned, or catheter-associated urinary tract infections, into a single consolidated number. It's usually expressed as a rate per at-risk patient days. This lets health systems track their overall system safety performance over time and compare it across different patient populations in various care sites. It gives a much more holistic and comprehensive view of safety across an organization rather than just looking at isolated incidents one by one.
Okay, so it's clear that healthcare is incredibly complex. It's definitely not a simple, linear process. We're talking about a complex system with countless providers, technologies, electronic health records, continuous physiological monitors, just so many dynamic interactions happening all the time. So with all that complexity, how do we even begin to understand what contributes to safety events? How do professionals actually make sense of it all?
Right, that's exactly where safety frameworks come into play. These are essentially conceptual models and practical tools designed to help clinicians, quality improvers, and researchers navigate this immense complexity. They provide a structured way to identify the myriad contributors to safe healthcare and, conversely, to safety events. Essentially, they offer a lens through which to view the entire healthcare system. They allow us to break down complex problems, identify potential root causes, and guide improvement efforts much more effectively. One foundational framework is the Donabedian framework. It's quite elegant in its simplicity, but also highly useful for evaluating quality and safety. It links three key components. Structure, that's things like the physical hospital resources, the number of staff, or the available technology, like do we have adequate nurse staffing levels. Then there's process, which is how care is actually delivered, the specific actions, protocols, and steps taken. For example, are nurses following a standardized hand hygiene protocol? And ultimately, there's outcome, which is the patient's health status, their mortality, or other measurable results like a reduction in infection rates. It's a classic tool for understanding how investment in resources and adherence to protocols hopefully lead to better patient results.
Simple, but powerful. What else is in the toolbox?
Well, then there's a more detailed approach, the Systems Engineering Initiative for Patient Safety, or SEIPS model. This framework actually emerged from an interdisciplinary effort involving human factors engineers, cognitive psychologists, and physicians. Its purpose is to provide more granular tools to understand the work system itself. It looks at the complex interactions between people, and crucially, this includes the patient and their family, not just clinicians, task work, the specific actions being performed, technology like EHRs, monitoring devices, 5E pumps, and the environment, the physical space, lighting, noise levels, even the organizational culture. It really dissects how all these elements interact to produce outcomes, both good and bad. The newest iteration, SEIPS 3.0, even introduces the concept of the patient journey. This is really important because it recognizes that a patient's interactions with healthcare often span multiple complex and, frankly, often separate care settings over time. Think about going from the emergency department to an inpatient unit, maybe to rehab, then outpatient follow-up. This shifts the focus from just looking at isolated points of care to the entire continuum. And that's where many handoff failures and diagnostic delays can occur, right? So that's where true safety must be maintained across the whole journey. And of course, there are other valuable frameworks out there from organizations like the Institute for Healthcare Improvement, which offer additional resources and perspectives for people to explore.
Okay, so you need these models to break down such a vast, intricate system. And speaking of models, one of the most famous And visually intuitive models in safety is definitely the Swiss cheese model. You see it everywhere for a reason, I think.
It is indeed. The Swiss cheese model, often depicted with those slices of Swiss cheese stacked up, it illustrates how multiple components of an organization's defenses are designed to prevent failures from leading to harm. Think of each slice of cheese as a layer of defense or a barrier. This could be anything from, say, robust staff training to specific hospital policies to advanced technology, clear communication protocols, or even simple tools like checklists. The holes in each slice represent individual failures or weaknesses in those barriers. Critically, the core idea of the Swiss cheese model is that harm may occur only when multiple defenses fail at the same time. It's when the holes in different slices of cheese momentarily align, allowing a hazard or an error to pass through every layer of defense and actually reach the patient. Let's use the wrong site surgery illustration from the source as a concrete example, the one shown in figure 5.2. I mean, this is a terrifying prospect for any patient, right? But the model shows it's rarely a single person's fault. Instead, it's often a confluence of seemingly small failures. Maybe it's the first day at a new hospital for a team member, and they're less familiar with the layout or specific equipment. Maybe new equipment was procured but never properly in service, so people don't know how to use it correctly. Perhaps a non-standard band was used to mark the surgical site instead of the standard clear surgical marker, making it ambiguous. There could be communication barriers, like a video translation system being down, forcing reliance on a less clear phone connection, or maybe the family doesn't speak English, hindering verification of critical details. And perhaps the history and physical exam weren't fully verified against the consent form before the procedure started. Each of these is a hole in a slice of cheese. When enough of these holes line up, what seems like an isolated wrong site surgery is revealed to be a profound systemic breakdown, where multiple defenses failed, aligning to allow the error to occur.
That's a really powerful illustration. It reinforces that these adverse events are rarely the fault of just one individual. They are often the result of systemic breakdowns, like a cascade of smaller failures lining up. It fundamentally shifts the conversation from blame to looking at how we can improve the system.
Exactly. And that leads us to a fascinating paradigm shift happening in safety science itself. For decades, the dominant approach to safety has been what we now call safety eye. Safety eye is the traditional approach, yeah. It primarily focuses on identifying what went wrong. We analyze near misses, errors, and actual harm events, meticulously dissecting them to understand the system failures that led to these incidents. The goal is to understand and improve the system that allowed these events to happen. It's fundamentally a reactive approach, right? Learning from what went wrong and trying to prevent it from happening again.
Okay, so that's safety I, looking at the failures. What's this emerging safety 2 then? Is it just ignoring the bad stuff?
Not at all. That's a common misconception, but it's not about ignoring failures. Safety 2 simply expands our perspective. While Safety 2 is about preventing things from going wrong, the emerging approach, Safety 2, focuses on what goes right. Think about it. In healthcare, there are vastly more things that go right every single day than go wrong. Millions of successful patient encounters, accurate diagnoses, perfectly administered treatments happen daily. It's easy to focus on the misses, but the real magic is in understanding why all those other moments go right, despite all the inherent complexities. Safety 2 seeks to understand how people act every day to create safety in complex and inherently unpredictable systems. This approach emphasizes that people are the greatest source of system resilience, especially in high-risk and stressful environments. Rather than just seeing human error as a problem to be stamped out, Safety 2 views human adaptation and ingenuity as part of the solution. It's about building upon those successful adaptations and understanding the hidden mechanisms of everyday safety. It's more proactive, designing systems that support more of what goes right, rather than solely reacting to failures after they happen. It's about building in the capacity to succeed even when things get challenging.
That's a really profound shift in thinking, moving from just fixing failures to understanding success. So if we're aiming for this kind of advanced safety, what are the practical tools and methods health systems use to identify problems and understand them deeply? How do they first become aware of unsafe conditions or potential issues on the ground?
Well, the first line of defense, and probably the most common, is incident reporting systems. Many health systems and hospitals provide electronic systems, or sometimes paper-based, though less common now, that employees can use to report errors, harms, or near misses they witness or are involved in. These systems are often designed to be anonymous, which is really crucial because it encourages healthcare workers to feel safe submitting an event report, even if they were involved, or if it involves someone in a position of authority. The ideal system facilitates smooth and efficient data entry, gathering enough information for review without being overly burdensome on the reporter. These systems definitely work best when there's a strong safety culture, we'll talk more about that later, where employees trust that their reports will actually be reviewed and acted upon, fostering that sense of psychological safety.
Okay, but you mentioned limitations earlier. They don't catch everything.
Right. There's a crucial limitation to incident reporting systems. They are known to dramatically underreport safety events. This is a major known gap. Many events simply don't get reported for various reasons, maybe fear of reprisal, lack of time, or maybe just not recognizing something as an event worth reporting. Because of this underreporting, other mechanisms are essential for learning about safety. One complementary tool is trigger tool systems. Instead of waiting for voluntary reports, these systems use specific triggers, like, say, a patient needing naloxone, the antidote for opioid overdose, or a patient being unexpectedly transferred to a higher level of care, like the ICU, to prompt a targeted medical record review by trained nurses and physicians. This proactive approach helps to uncover errors or system risks that might otherwise be missed entirely through voluntary reporting alone. It's like actively searching for potential problems based on known warning signs.
That makes a lot of sense. You can't just rely on people raising their hands. So how else do professionals train for these high-stakes, complex situations without putting actual patients at risk? How do they learn to anticipate failures and practice teamwork, especially under pressure?
That's where simulation becomes such an excellent tool. It allows health systems to better understand system flaws and those latent threats we talked about before they cause harm in real patient care. There are a couple of primary types. First, we have high-fidelity simulation. This typically involves using highly realistic mannequins that can reproduce or mimic human anatomy and physiology. They can breathe, have heartbeats, react to interventions. It allows clinicians to practice technical skills like maybe performing intubation in an emergency in a completely safe, controlled environment. But perhaps even more importantly, high-fidelity simulation is invaluable for helping clinical teams improve crucial non-technical skills. These are those vital soft skills like closed-loop communication, where a message is sent and then explicitly confirmed by the receiver, ensuring clarity and understanding under pressure. It also helps teams develop a shared mental model, meaning everyone on the team is on the same page about the patient's condition and the immediate plan of care. For example, a team leader might state, okay, I believe this patient has septic shock. We are rapidly infusing fluids and giving antibiotics. Blood pressure is normal for age right now. What other thoughts does the team have? This fosters shared understanding and actively invites input, building critical teamwork. A huge benefit is that it's far easier and, frankly, more feasible to give constructive, immediate feedback in a simulated scenario compared to trying to debrief during or right after a real high-stress event.
And the low-fidelity kind. Less fancy, but still useful.
Exactly. Then there's low-fidelity simulation. This doesn't require those costly simulated patients or advanced equipment. Its big advantage lies in its ability to identify latent threats directly within the actual hospital or clinic environment where care happens. For example, you could run a simulated scenario right on a medical surgical unit, maybe a mock code, and it might reveal that the nurses don't actually know where to quickly find a CPAP mask for an infant experiencing respiratory failure. This exposes a hidden system vulnerability, a latent threat maybe in the supply chain or in staff training or equipment location. Identifying and then mitigating this latent threat in a simulated environment, perhaps by clearly labeling where these masks are stored or ensuring they are readily available on a crash cart, is vastly preferable to discovering this critical gap during an actual emergency with an acutely deteriorating child.
Yeah, finding it in practice rather than in crisis makes total sense. It's incredibly proactive. It really shows how you can find problems before they even become problems for patients. But okay, once an event does occur, whether it's a near miss or actual harm, how do teams truly learn from it? How do they dig deeper than just the surface level to find the root causes and prevent it from happening again?
Right, that's where event analysis comes in. And there's really a suite of methods, each with its own strengths and weaknesses, depending on the severity and complexity of the event. The most robust and, frankly, time-intensive is root cause analysis, or RCA. This is a really detailed process designed to ascertain the most fundamental or root causes of a significant safety event. The Joint Commission actually requires RCAs for sentinel events, which are those most serious, often catastrophic events. Most health systems reserve RCAs primarily for these types of events, because honestly they can take months to complete and require convening a dedicated multidisciplinary team of experts, everyone from physicians and nurses involved to pharmacists, equipment specialists, maybe even administrators. The core focus of an RCA isn't about blaming a person. It deliberately moves past that to understand the system, the underlying hazards, the hidden errors, the process breakdowns that allowed the event to happen. The team works diligently to go beyond the immediate event to its deeper underlying causes. For instance, the source provides a classic example. Enteral formula feeds, like baby formula, being accidentally connected to and administered through a central intravenous line. A terrible error. The event itself is the dangerous misconnection. The proximal cause, the immediate reason, is that the feeding tube and intravenous tubing are visually identical and are easily attached. They look the same, they fit together. But the root cause? Perhaps the investigation reveals the organization lacks a system to assess human factors risks as new equipment is procured and put into practice. Nobody checked if these visually similar tubes could connect before they were introduced. When these deep root causes are identified and then tied to robust improvement action plans, for example, we will design feeding tubing and intravenous tubing to be distinct and incompatible to prevent misconnections, then safety can be substantially and hopefully lastingly improved. However, RCAs aren't perfect. They do have challenges. Hindsight bias is a significant risk. Knowing the bad outcome can unconsciously influence how people perceive past events, making everything seem obvious in retrospect. Oh, we should have known. There's also the risk of overfitting solutions, meaning designing complex protocols to prevent one very specific event that might inadvertently introduce new problems or safety threats elsewhere in the system. And finally, spreading solutions identified in one RCA from, say, the ICU to a general pediatric floor, which often have different needs, workflows, and patient populations, can be really difficult. What works in one place doesn't always translate easily.
Okay, so an RCA is the really deep, months-long dive for the most serious events. What about this apparent cause analysis? Is that for something maybe less catastrophic, but still important to look into?
Exactly. Apparent cause analysis is typically performed by a smaller multidisciplinary team and focuses primarily on the proximal causes, those more immediate factors contributing to the event. This makes it much more feasible for events that occur more frequently, but are still significant. Things like the wrong medication is consistently being sent from the pharmacy to a specific unit. The key questions here are how likely the event is to recur and how widespread these proximate causes are in the specific microsystem, like that unit where it happened. This allows for quicker, more targeted interventions without the massive resource investment of a full RCA. Then there's common cause analysis. This method is interesting. It seeks to aggregate learning across multiple different events to identify a single, similar common cause that may be contributing to various safety issues. For example, maybe investigators noticed that poor handoff procedures seem to be implicated in both a missed laboratory check on one patient and a delayed diagnosis on another patient on a different day. Identifying this common underlying issue, poor handoffs, helps leaders address that systemic problem more effectively across potentially multiple departments or units. And finally, a really powerful proactive tool is failure mode and effects analysis, or FMEA. Clinicians use FMEA before something goes wrong. They meticulously describe a process, maybe a new workflow or using a new device step by step. Then they brainstorm and identify every conceivable failure mode, all the ways in which each step might fail or go wrong. A more robust form of FMEA actually quantifies these potential failure modes in 3 categories: the probability of the event occurring, its potential severity if it does occur, and its ability to be detected before it reaches the patient. The product of these 3 factors is called the risk priority number, or RPN. The RPN helps teams prioritize which potential failure modes to target first with preventative measures because they pose the greatest potential harm and risks to the system. It's all about anticipating and preventing failures rather than just reacting to them after they happen.
Okay, it's clear that having all these tools and frameworks is essential. But beyond the checklists, the analyses, the simulations, what's the underlying foundation for true, sustainable safety? What's the maybe invisible architecture that holds it all together and makes it all work effectively?
Yeah, you've really hit on the most critical element. A broad and supportive safety culture. This is widely recognized now as the fundamental driver for both patient safety and, importantly, employee safety as well. A truly mature safety culture fundamentally shifts the narrative within an organization. It fosters a culture of learning and treats errors not as personal failures of individuals, not as something to be ashamed of or punished for, but rather as valuable opportunities to improve the system. This completely transforms every incident, every near miss, into a potential lesson, moving away from a punitive, blame-focused environment towards one of continuous growth and improvement. It's a huge mindset shift, moving from blame to learning.
So how do you achieve that balance then between
Learning from errors, which requires people to be open, and still maintaining accountability. How do you make sure people are responsible for their actions without fear shutting down that honest reporting you need?
That's precisely what the concept of just culture aims to achieve. It's a really nuanced approach that carefully differentiates between, say, mistakes and wrong decisions that are maybe commensurate with a clinician's training and experience, these are learning opportunities we just discussed, versus things like willful violations of known safe practices or gross or repeated patterns of negligence, which quite rightly do require different, more stringent responses. The purpose of implementing a just culture is to create an environment where people feel psychologically safe to report errors, near misses, and system vulnerabilities without fear of unjust punishment, while still holding individuals accountable for their choices and professional responsibilities. It's about understanding intent and context, not just the outcome. It builds trust, which is absolutely essential for getting those valuable reports. A strong safety culture is built upon several key components working together. It fundamentally prioritizes clear and consistent communication and teamwork. That has to be front and center. It actively works to ease authority gradients, which we'll dig into more in a moment, basically reducing hierarchical barriers that might prevent someone from speaking up. Organizations also need to actively measure their safety culture using validated tools like the Safety Attitudes Questionnaire or the AHRQ surveys on patient safety culture. This provides data to identify areas for improvement and track progress over time. You can't improve what you don't measure, right? A robust culture also explicitly supports smooth handoffs and responsibility transfer, both within disciplines, like nurse to nurse at shift change, and across disciplines, such as when a nurse needs to call a physician with a concern about a patient, because we know these transitions are high-risk moments for information loss.
So structured communication fits in there too.
Absolutely. This culture also champions structured communication tools like the SBAR approach, that's situation, background, assessment, recommendation. These are highly valued for facilitating clear, concise, and complete communication, especially in urgent or complex situations. It gives everyone a common framework, and it encourages specific safety behaviors like repeat back or write back, where a critical piece of information, maybe a critical lab result or a verbal medication order, is shared and then verbally repeated back by the receiving clinician to ensure accuracy and mutual understanding. These simple behaviors can significantly reduce miscommunication risks.
Let's talk more about those authority gradients you mentioned, because power dynamics are very real in healthcare settings, aren't they? You have senior physicians, residents, experienced nurses, new nurses, students, all with different levels of experience and perceived authority. How does a safety culture navigate that hierarchy to encourage everyone to speak up when they see something?
You're exactly right. Authority gradients are quite real in healthcare. They reflect the inherent hierarchy in medicine and nursing. In an ideal safety culture, however, the goal is for both junior and senior clinicians to work together collaboratively across disciplines, and for everyone to feel empowered to speak up when concerns are identified, to feel comfortable asking questions, and crucially, not to proceed if there is uncertainty about safe patient care. This requires a real shift from a traditional top-down command and control approach to one where expertise and valid concerns are valued, regardless of someone's positional authority or title.
And leadership has a big role there, I imagine.
A critical role. Health system leaders have to actively model and support this culture. They must orient new employees to its importance and, critically, be prepared to intervene if they see authority gradients or other disruptive behaviors contributing to safety events or creating unsafe conditions. This isn't always easy. It can involve difficult conversations, but it's absolutely essential for fostering an open and genuinely safe environment. And to specifically address the negative impact of hierarchy, recent efforts have focused heavily on building psychological safety. This is defined as the ability to raise concerns and ask questions without the fear of negative consequences for self-image, status, or career. Imagine being a junior nurse who thinks they might have spotted a potential error by a senior respected physician. Without psychological safety, you might hesitate to speak up, right? And that hesitation could tragically lead to patient harm. This concept is absolutely critical for multiple aspects of a healthy safety culture. It enables establishing a shared mental model among the team. It allows for effective event reviews and debriefs where people feel safe being honest. It helps address professionalism concerns. And it's fundamental for fostering truly collaborative partnerships with patients and families to pursue shared safety goals. It is, quite simply, the bedrock of a learning environment where people feel safe enough to be vulnerable, to ask questions, and to learn together without fear.
Okay, so we've talked about understanding what goes wrong, what goes right, and the crucial culture that supports learning and speaking up. But when we look at healthcare processes themselves, How reliable are they truly? What does reliability even mean in a clinical setting day to day?
Right. Reliability in healthcare is specifically defined as the measurable capability of a process, procedure, or health service to perform its intended function in the required time under commonly occurring conditions. In simpler terms, it's about how consistently a healthcare process delivers the expected safe outcome every single time. The sobering reality, however, is that most processes in healthcare organizations currently perform at what we call level 1 reliability. That means a success rate of only about 80% to 90%. That translates to a 10% to 20% failure rate, which is frankly unacceptable for critical patient care. I mean, imagine if your airplane had a 10% to 20% chance of a critical system failure every time you flew. We simply wouldn't tolerate that risk in other industries.
Wow. 80-90% sounds okay until you frame it as a 10-20% failure rate.
Yeah.
So how do you get better?
Well, to achieve higher reliability, we need intentional design, borrowing principles from other fields like engineering and human factors. Level 2 performance, which aims for 5 failures or fewer per 100 opportunities, so 95% success or better, requires processes to be intentionally designed using these tools and concepts. This includes strategies like creating intentional redundancy, such as requiring an independent double check on high-risk medication dosing, meaning 2 qualified people check the dose calculation and the medication before it's given. Another powerful strategy is making the default action the desired action based on evidence. For example, setting up the system to default to ordering an influenza vaccination for high-risk asthma patients so it happens automatically unless a clinician specifically opts out for a valid reason. This makes the safer, evidence-based choice the easier one to make. Moving to level 3 performance, which targets 5 failures or fewer per 1,000 opportunities, that's 99.5% success or better, demands an even more rigorous and systemic approach. This requires a well-designed system with low variation, where processes are highly standardized and predictable, leaving less room for error. It also necessitates strong cooperative relationships among all team members and a state of organizational mindfulness, which means a constant, active attention to processes, their structure, and how they relate to outcomes. It's about being acutely aware of what's happening in the moment, constantly looking for small deviations or potential risks before they escalate.
That brings us to other industries again. Where else can healthcare look for inspiration on achieving such incredibly high levels of safety and reliability, especially when the stakes are so incredibly high?
Yeah, healthcare can absolutely learn significant lessons from disciplines like human factors engineering and cognitive psychology, which are often expertly applied in other high-risk fields. Industries that have really mastered these principles and robustly identify and mitigate threats and use simulation extensively are often termed high reliability organizations, or HROs. These are industries like commercial aviation, air traffic control, nuclear power operations, even aircraft carrier flight decks. They achieve truly exemplary safety records under incredibly dynamic and inherently high-risk conditions. They have, in many ways, perfected the art of operating safely in dangerous environments, and healthcare is actively studying their practices to adapt their principles to the unique challenges of medicine.
Okay, so what are the core principles? What do these HROs actually do?
HROs achieve this high reliability through the consistent application of 5 core tenets or principles. First, they have a preoccupation with failure. Now, this might sound negative, but what it means is that surprises, errors, even small deviations, are viewed not as something to be hidden or explained away, but as critical learning opportunities. Lessons learned from even minor issues spread quickly throughout the organization. They don't ignore small problems because they know they can be precursors to larger ones. They are constantly, proactively looking for the next potential vulnerability. Second, there's a reluctance to simplify interpretations. When serious safety events do occur, HROs insist on thorough, deep analysis, much like the root cause analysis we discussed earlier. They resist the temptation for quick, superficial explanations that might scapegoat an individual or miss underlying systemic flaws. They always dig for the true, complex underlying causes. Third is sensitivity to operations. HROs maintain a constant, proactive awareness of what's actually happening on the front lines in real time. They use tools like proactive risk assessments and regular huddles, those brief team meetings, to identify and target risks to the operation, or in our case to patients, and the organization, focusing on the immediate operational realities and any emerging threats as they develop. Fourth, they demonstrate a profound commitment to resilience. Errors, they recognize, will still sometimes happen despite best efforts, but errors do not disable their systems. HROs are designed to anticipate and successfully negotiate high-risk, uncommon scenarios. They have built-in redundancies and adaptive capacities that allow them to bounce back effectively from unexpected events, ensuring that a single failure doesn't cascade into a catastrophe. They essentially build systems that can fail gracefully and recover quickly. And finally, number 5, there's a deference to expertise. Leaders in HROs understand when to defer to frontline experts when their specialized knowledge or situational awareness is required. This means valuing practical experience and real-time information over hierarchical position or rank. They ensure that the person with the most relevant information or skill at a given critical moment is the one whose voice is heard and respected, even if they are lower in the formal organizational chart. Expertise trumps hierarchy in critical situations.
Okay, this all sounds incredibly sophisticated, almost theoretical in some ways. But where has this intense focus on safety, these frameworks, these high reliability principles, where have it made a tangible, real difference in patient care, especially for kids?
Oh, it absolutely has. There has been substantial improvement in patient safety that has occurred precisely because improvement teams have rigorously targeted these serious harm events. A powerful metric used to track this progress, as we mentioned briefly, is the serious harm event rate. Remember, this is a composite metric that groups various preventable healthcare associated conditions, or HACs, into one single number, usually expressed as a rate per, say, 1,000 at-risk patient days. This allows an organization or a collaborative like SPS to track its overall system safety performance over time and to compare it across different patient populations in various care sites. It provides a much more holistic view of safety trends and allows for clearer tracking of whether interventions are actually working across the board. And when you look closely at the successful improvement teams that have tackled these HACs, there are strong commonalities. They typically involve multidisciplinary team membership, doctors, nurses, pharmacists, infection control, everyone needed. They have very clear outcome definitions and measurement strategies for each condition they're targeting. They build robust learning systems focused specifically on each HAC. And they pay balanced attention to both process measures, are we doing the right things, and outcome measures, are those actions leading to fewer harms. This dual focus is critical. It ensures that not only are the right evidence-based practices being implemented reliably, but they are also actually leading to the desired positive impact on patient safety.
Okay, so let's walk through some of the key examples from our source material, maybe highlighting the costs involved, which would be staggering, and the effective interventions that have been developed and proven to work.
Sure. Let's start with central line-associated bloodstream infections, or CLA-BSIs. These are serious, laboratory-confirmed bloodstream infections in a patient who has a central venous catheter, or central line. They are incredibly costly, estimated at about $55,646 per event, and tragically, they can be life-threatening. Effective interventions are often bundled together. There is usually a strict line insertion bundle, which covers actions like meticulous hand washing, using maximum sterile barrier precautions during insertion, and using a chlorhexidine skin scrub. And then there's a line maintenance bundle, which involves consistent catheter care, specific dressing change protocols, and importantly, daily discussions among the team about whether the central line is still medically necessary. These bundles standardize the process and significantly reduce infection risk when followed reliably.
$55,000 per infection. That's huge, besides the patient impact. What else?
Then there are catheter-associated urinary tract infections, or CIUTIs, costing around $7,200 per event. These are infections linked to indwelling urinary catheters. Interventions here often include strict protocols for daily review and prompt removal of urinary catheters when they're no longer medically indicated, getting them out as soon as possible. Also ensuring clear, evidence-based indications for inserting them in the first place. Having physician and nurse champions who actively lead the charge to reduce unnecessary catheter use makes a big difference. And consistent audit and feedback of data showing teams their catheter use rates and infection rates helps drive improvement. Adverse drug events, or ADEs, carry an average cost of around $3,659 per event, though some can be much more costly depending on severity. These are injuries resulting directly from medication use, wrong drug, wrong dose, allergic reactions, side effect. Interventions that have proven effective include rigorous pharmacist review of medication orders before dispensing, the widespread use of computerized physician order entry, or CPOE, systems which can automatically flag potential drug interactions or incorrect dosages based on patient factors, And even seemingly simple things like standardizing order sets to automatically co-order laxatives for patients prescribed opioids can prevent common, predictable side effects like constipation. These interventions act as important checks and balances in the complex medication use process.
It's really remarkable how these very specific, often bundled, targeted interventions can lead to such significant improvements. And our source includes a fantastic example of the power of this process, an outcome improvement focus, with a CLA BSI case study, the one illustrated in Figure 5.3. It really brings it all to life visually.
It really does. This specific CLA BSI project is a prime example of how focusing relentlessly on reliable processes directly translates to vastly improved patient outcomes. The interventions in this particular project specifically targeted two key process measures known to be absolutely critical in preventing CLA BSIs: adherence to the line insertion bundle practices and adherence to the line maintenance bundle practices. The goal was simply to increase compliance, to get teams doing these evidence-based practices reliably every single time. And the results, as shown in the figure, were dramatic. Performance for the line insertion bundle improved from a pretty dismal 46% adherence initially up to an impressive 95% adherence after the interventions. The line maintenance bundle also saw significant improvement, going from only 13% adherence up to 66%. And here's the crucial part, the outcome. Coincident with these dramatic improvements in process adherence, the actual rate of CLA BSIs in that patient population plummeted from 17.6 infections per 1,000 central line days down to a mere 2.5 per 1,000 line days.
That reduction in CLA BSIs, from 17.6 down to 2.5, that's genuinely remarkable, isn't it? What do you think made that particular project so successful that it could achieve such a dramatic shift? It feels like more than just checklists.
Well, I think it's a perfect illustration of the core principles we've been discussing all along. Having a clear problem definition, CLA BSIs are bad and costly, engaging a multidisciplinary team, implementing rigorous measurement of both process and outcome, and maintaining a relentless focus on improving the reliability of those key processes. It also really underscores the power of a learning network model, like the one used by the SPS Collaborative. By sharing these successes, the specific interventions, the lessons learned, and the effective strategies across many different children's hospitals, they accelerate progress much faster than any single hospital could alone. This isn't just theory, it's a practical blueprint for tangible change and a real testament to the power of collective effort and shared learning in improving safety.
So beyond these maybe more established healthcare-associated conditions like CLA BSIs and CUE, what are the other critical frontiers of safety in pediatric care? Where are the next big opportunities and maybe the significant gaps that the field is actively working on right now?
Yeah, that's a great question. One major area, which unfortunately often leads to substantial and preventable harm, is the issue of unrecognized clinical deterioration in hospitalized children. The key insight here from years of research is that serious deterioration, like a child needing emergency resuscitation, is rarely a sudden, completely unpredictable event. Instead, it's almost always preceded by subtle, sometimes not so subtle, abnormal vital signs, and often concerns voiced by patients, families, or the bedside clinicians who notice something just isn't right with the child. The signs are often there, but sometimes not recognized or acted upon quickly enough.
So how do hospitals try to catch that earlier?
To address this challenge, rapid response systems, or RRS, have been very widely adopted. These systems are specifically designed to detect deterioration earlier and then rapidly deploy critical care expertise, like an ICU nurse or physician, to the patient's bedside outside of the ICU. The goal is either to intervene and stabilize the patient right there on the floor, or, if needed, to escalate care smoothly and quickly to an intensive care unit. While there's some variation in exactly how they are activated and who responds, essentially all U.S. children's hospitals now have some version of an RRS, and their impact appears significant. Studies have associated RRS implementation with substantial reductions in cardiopulmonary arrest, or CODES, occurring outside the ICU, and also reductions in overall in-hospital mortality. A key tool used in this early detection effort is Pediatric Early Warning Scores, or PEWS. Many large children's hospitals now use PEWS routinely to help identify deteriorating patients sooner. These scores assign points based on abnormalities in age-adjusted vital signs, like heart rate, respiratory rate, blood pressure being too high or too low for that age, and also incorporate key nursing assessments, such as changes in mental status or signs of poor perfusion, like slow capillary refill. Importantly, PEWS take these diverse assessment elements and combine them into a single objective score. This score is then typically linked with clear expected actions. For example, maybe a score of 5 triggers an automatic physician evaluation, while a score of 7 triggers an immediate rapid response team activation. This structured approach significantly improves the early detection of deterioration and consequently patient safety outcomes by providing a standardized alert system that reduces subjectivity.
So PWS helps with knowing when something might be wrong. How does that fit into the bigger picture of awareness?
Right. PVWS are essentially a method for improving a clinician's overall situation awareness. This is that critical sense of what is going on with the patient right now, what is important among all the data, and the ability to anticipate future consequences or potential trajectories. Maintaining this acute awareness is incredibly challenging in dynamic, high-risk environments like healthcare, where patient conditions can change very rapidly and there's a lot of information coming at you. Several children's hospitals have pioneered proactive strategies beyond just PWS to enhance situation awareness, and they've seen sustained significant reductions in unrecognized clinical deterioration. These strategies include the systematic and proactive identification of watcher patients, those children whom a nurse, physician, or even the patient's family subjectively feels are close to the edge of deterioration, even if their vital signs aren't drastically abnormal yet. Gut feeling matters. These identified high-risk patients might then be discussed more formally at multidisciplinary bedside huddles where specific treatment plans and predictions about potential problems are outlined explicitly. Any concerns raised by anyone on the team, including the family, are more fully addressed through the rapid response team pathway, and perhaps also at broader hospital-wide safety huddles or daily safety rounds. In fact, to get an even better sense of overall organizational safety and emerging threats across the hospital, many hospitals in the SPS Collaborative now employ a daily safety or operations brief. During these short, standing meetings, leaders from various service lines like inpatient care, pharmacy, perioperative services, maybe even facilities, quickly discuss unexpected events or safety concerns from the past 24 hours and rapidly develop solutions and follow-up plans to mitigate any emerging cross-disciplinary threats. This ensures rapid, proactive system adjustments based on real-time information.
And what about learning after something does happen, like a code or a near-miss deterioration?
Yeah, event debriefs and reviews are particularly relevant and important for instances of clinical deterioration. They serve multiple crucial purposes. First, allowing for emotional processing and support for the staff involved, which can be very stressful events. Second, providing a structured forum for discussing the care process itself and the team's performance during the event. And, critically third, the development of concrete action plans to improve care processes or systems in the future based on what was learned. The Pediatric Resuscitation Quality Collaborative, or PIDI-RESQ, actually classifies debriefs into two useful types. Hot debriefs, which ideally occur minutes to hours after the event, allowing for that immediate emotional processing and maybe some quick educational discussion while memories are fresh. And then cold debriefs, which happen days to weeks later, providing a much more comprehensive multidisciplinary review of all the data and feedback, often focusing more on identifying and addressing systemic changes needed. Current research in this area is really focused on developing successful frameworks and tools to guide these debriefing discussions and ensure effective action plan development, like formal processes for classifying and systematically reviewing cardiac arrest events that occur in pediatric ICUs to learn from every single one. Now, while tracking cardiopulmonary arrest rates outside of the ICU is a useful metric for rapid response systems in adults, these events are thankfully quite rare in pediatrics, especially since RRS became widespread. Therefore, a major focus of research and quality improvement efforts now is identifying valid, more frequent proximal metrics to arrest things that happen more often and signal risk before a full arrest occurs. Our source highlights several of these metrics in Table 5.2, each with its own strengths and limitations, for identifying risk factors and evaluating RRS effectiveness. These include things like unplanned ICU transfers, specific critical deterioration events like needing non-invasive ventilation, emergency intubation or vasopressor medications after an ICU transfer, emergency transfers, meaning an urgent transfer, usually due to a sudden decline requiring immediate critical care support, and broader definitions of significant clinical deterioration events. Also tracked are specific code events like confirmed cardiopulmonary arrests, CPAs, and also acute respiratory compromise, ARC events that require urgent intervention but might not progress to a full arrest. Each of these gives a different window into the effectiveness of early detection and intervention systems, allowing for more frequent, real-time monitoring of safety performance in this area.
Okay, that's incredibly thorough on the deterioration front. But beyond these acute events, there's another type of error that I imagine can be incredibly frustrating for patients and families, and often has a profound impact. Diagnostic error. This must be a huge frontier in patient safety efforts.
It absolutely is. Diagnostic error is recognized as an increasingly common and impactful type of safety event, with some estimates suggesting that maybe 10% to 15% of diagnoses might be incorrect or delayed. That's a staggering figure when you think about the consequences, right? An incorrect diagnosis can lead to delayed necessary treatment, unnecessary or even harmful treatment, or even no treatment at all for a serious underlying condition. Understanding why these errors occur often comes down to understanding how clinicians actually make decisions under uncertainty. Cognitive psychologists describe two main systems of clinical decision making: System 1 and System 2. System 1 thinking is fast, intuitive, pattern recognition based, and largely unconscious. It relies heavily on heuristics or mental shortcuts and can be significantly influenced by cognitive biases. It allows for quick, almost automatic decision making, often by associating new information with existing patterns or beliefs stored in memory. Think of it like instantly recognizing that red octagonal sign on the right side of the road is a stop sign. I should stop. It's incredibly efficient for routine situations where patterns are reliable. However, System 1 thinking can be dangerous in diagnosis, particularly when new data are unconsciously made to fit a preconceived diagnostic pattern and evidence that doesn't fit the pattern is ignored or downplayed. This can lead directly to misdiagnosis.
And System 2 is the opposite.
Exactly. System 2 thinking is slow, effortful, analytical, cognitive, and calculating. It involves deliberate analysis, critical thinking, and a conscious evaluation of all available information, systematically weighing evidence for and against different possibilities. It's the kind of thinking you engage when you're solving a complex math problem or really digging into a difficult clinical puzzle where the answer isn't immediately obvious. A lot of current research aims to better understand how these well-described cognitive biases, which are essentially predictable flaws or shortcuts in our System 1 thinking, play out in actual clinical care and what system-based strategies can help mitigate their negative effects on diagnosis. For example, we see biases like anchoring, where a clinician locks onto an initial diagnostic impression and then struggles to adjust their thinking even when new, contradictory information comes in. Or premature closure, which is accepting the first plausible diagnosis that comes to mind before systematically considering all alternatives or getting all the evidence. This leads to that common and dangerous saying in medicine, when the diagnosis is made, the thinking stops. These are just two common ways our brain, surprisingly, can lead us astray in critical diagnostic moments, highlighting the inherent challenge of human cognition in complex, high-stakes environments. Other important biases include things like confirmation bias, where we only seek out or pay attention to evidence that confirms our initial hypothesis, and diagnostic momentum, where a diagnostic label applied by a previous clinician gets perpetuated over time without critical reevaluation.
Okay, so knowing these biases exist is one thing. What are the practical strategies to actually mitigate diagnostic errors?
Well, the overarching goal is often to encourage clinicians to consciously shift from automatic System 1 thinking to more deliberate System 2 thinking, especially when the situation is complex, atypical, or doesn't quite fit the expected pattern. This includes things like being explicit about uncertainty. For example, maybe admitting patients from the emergency department with an uncertain diagnosis label to encourage fresh evaluation rather than prematurely labeling them. Or using clinical decision aids or checklists that prompt clinicians to revisit provisional diagnoses and systematically consider alternative possibilities. One powerful structured tool is the diagnostic timeout, which is detailed in Table 5.6 in the source. This is essentially a structured pause for critical thinking, ideally done collaboratively. During a diagnostic timeout, the team would explicitly identify the specific clinical issues or diagnostic dilemmas needing the pause. Then they'd consciously try to remove all previous diagnostic labels and re-examine all the available laboratory studies, imaging results, and other information, including the history and physical exam findings, ideally with fresh eyes. They'd explicitly consider the risks of heuristic thinking in the specific case and ask themselves if any known biases might be influencing their judgment. Crucially, they'd actively brainstorm and identify the must-not-miss diseases, the potentially life-threatening conditions that need to be ruled out, ensuring these aren't overlooked in the focus on a more common diagnosis.
Teamwork seems key there, too.
Absolutely. Another vital strategy is promoting team-based thinking, often called collective intelligence. Leveraging multiple perspectives from different clinicians, doctors, nurses, pharmacists, specialists, can help identify blind spots or biases that an individual clinician, no matter how experienced, might miss on their own. It adds layers of review, discussion, and cross-checking. And, as always, a strong safety culture is absolutely critical here because it fosters the open acknowledgement of diagnostic uncertainty. It creates an environment where clinicians feel safe saying, I don't know, or I'm not sure, and where there's a willingness to openly discuss and learn from diagnostic errors when they inevitably occur without a culture of blame or fear of punishment. The 2015 National Academy of Medicine NAM report, titled Improving Diagnosis in Healthcare, was a real landmark document in this field. It heavily emphasized the centrality of communication to patients and families throughout the entire diagnostic process. They are key partners. The report introduced a detailed diagnostic process model, which is shown in Figure 5.4, and it describes these iterative cycles of information gathering, followed by integration and interpretation of that information, leading to the formulation of a working diagnosis, which then might lead back to more information gathering. It's a continuous loop. And a key insight from that NAME report was the emphasis on the diagnostic team. This team crucially includes not just doctors, but also nurses in various practice contexts, like the ED nurse who first sees the patient, or the primary care nurse who knows their history, pharmacists who understand medication effects, respiratory therapists, and most importantly, patients and their families themselves. The report stressed that strategies leveraging this entire diagnostic team, as opposed to simply relying on the cognition of busy individual clinicians working in silos, are particularly well positioned to improve both patient-level and system-wide diagnostic outcomes. It's really a collective intelligence approach that recognizes the valuable input and unique perspective that every member of the care ecosystem, including the patient, brings to the table. Our source provides a really comprehensive summary of specific strategies to avoid diagnostic errors in Table 5.7, which is a fantastic roadmap for any listener looking to master this complex area. It highlights the importance of things like enhancing foundational medical knowledge, knowing symptoms, red flags, minimizing those heuristic failure errors by understanding System 1, System 2 thinking, and using techniques like counterfactual reasoning. What else could this be? It talks about mitigating attribution errors through self-reflection and embracing a team approach. It also emphasizes avoiding context errors by seeking multi-specialty input and avoiding thinking only within one's own specialty silo. It stresses optimizing data gathering by developing broad differential diagnoses, considering atypical presentations, relying on objective data, and questioning previously accumulated diagnostic labels. And it covers improving hypothesis testing by understanding the limitations of lab tests, considering post-test likelihoods, acknowledging that the initial diagnosis may change, using evidence-based guidelines, being open to disconfirming data, and knowing what you don't know. Finally, for those really complex, undiagnosed, or rare cases, it stresses the importance of maintaining healthy skepticism, using methodical analysis, constantly questioning the working diagnosis, considering the possibility of multiple concurrent diseases, incorporating all available data, even seemingly minor points, never saying never about rare conditions, using a strong team approach, considering atypical or rare manifestations of common diseases, and performing extensive literature reviews when needed. It's a whole toolkit for diagnostic safety.
Wow, that's an incredibly deep dive into diagnostic error alone. And it's so helpful to see those specific biases and concrete strategies laid out like that. Okay, so moving from the complexities of diagnosis, how do patients safely transition between different care providers or even between different units within a hospital? That handoff process seems like another incredibly vulnerable point for errors to creep in.
You're absolutely right. Handoffs are widely recognized as a critical point of vulnerability in healthcare continuity and safety. There's a growing body of evidence highlighting the potential negative consequences of poor handoffs. Things like missed critical information, delays in necessary care, medication errors, or even major adverse events, and also demonstrating the effectiveness of targeted interventions to improve them. Probably the best studied intervention, particularly for the common resident-to-resident shift handoffs in teaching hospitals, is the IPASS mnemonic and its associated system.
IPASS, what does that stand for?
Yeah, IPASS stands for illness severity. How sick is the patient? Patient summary, what's their story? Action list, what needs to be done? Situation awareness and contingency planning, what might go wrong and what's the plan if it does? And synthesis by receiver, where the incoming person summarizes their understanding to ensure accuracy. It provides a structured, standardized, and memorable way for residents and potentially others to communicate vital patient information during those critical transitions of care, ensuring all critical details are conveyed clearly and understood accurately. In a large 9-hospital study, the implementation of the IPASS handoff bundle, along with its supporting educational curriculum, led to a really significant 23% reduction in reported medical errors and an even more impressive 30% reduction in actual adverse events related to handoffs. This structured approach has also been successfully adapted and shown promise for improving communication during other high-risk transitions, like from the ICU back to the general floor, from the operating room to the ICU, and even from the inpatient medical team discharging a patient back to their primary care provider in the community. It's a powerful testament to the impact of just improving structured communication and standardization at these critical junctures in care.
Wow, that's a huge impact just from a better communication tool and process. Okay, now let's shift gears slightly and talk about something I hear about more and more. The sheer volume of alerts and alarms in a modern hospital setting. I mean, imagine trying to focus as a nurse or doctor with hundreds of beeps and alerts going off around you all day long. It must be incredibly distracting, and I hear it leads to something called alarm fatigue.
Indeed, alarm fatigue is a very real and actively researched area of concern and improvement in patient safety. It occurs when healthcare providers are exposed to such a high volume of auditory and visual interruptions. Some studies have documented environments with up to 400 alarms per patient daily, many of which turn out to be non-critical or false alarms, that they understandably become desensitized over time. This desensitization can lead them to respond more slowly to alarms, or even worse, they might inadvertently dismiss or miss a potentially relevant, truly critical alarm amidst all the noise. Current interventions being tested and implemented include strategies like removing monitors altogether from patients who are clinically stable and unlikely to benefit from constant monitoring, designing smart alarms that use algorithms to only alert for truly critical combinations of parameters. For example, alerting for bradycardia only when it occurs simultaneously with hypoxia rather than for every single transient dip in heart rate, and using advanced communication technology systems that can help safely escalate true actionable alarms directly to the right caregiver while filtering out many of the non-actionable ones at the source. And there's a closely related concept often discussed alongside this, which is alert fatigue. This refers specifically to clinicians becoming overwhelmed by and potentially ignoring electronic health record, EHR alerts like pop-ups for potential medication interactions or reminders for routine care, due to the sheer volume of these alerts, many of which are often perceived as non-actionable, clinically irrelevant, or repetitive in the moment. It's a significant information overload problem that can paradoxically lead to missed important warnings, and it represents a major challenge in optimizing the safety benefits of modern digitized healthcare systems.
Okay, so from the general hospital environment and its noises, let's zoom in on a very specific high-stakes area, surgical safety. Surgical errors, things like operating on the wrong patient or the wrong body part, are some of the most terrifying imaginable for patients. How has that high reliability thinking been applied to really prevent those kinds of catastrophic mistakes?
Yes, surgical safety has seen significant strides, often driven initially by the public and professional response to those very distressing reports of wrong patient or wrong site surgeries. Perioperative leaders, working with safety experts, developed a set of core safety strategies, often termed the tenets of surgical safety, which are now strongly endorsed by organizations like the World Health Organization, WHO. These tenets are typically implemented as several discrete checklists that are performed at key timeouts or pauses during the course of a surgical procedure. Multiple large-scale studies have conclusively demonstrated that the implementation of these surgical safety checklists leads to reduced harm to patients, including lower rates of complications and mortality. As a result, surgical checklists are now very widely adopted, often mandated, throughout surgical and procedural environments globally.
So when do these checks happen? What are the key moments?
Typically, these checklists are used at 3 key times during a procedure. First, before the induction of anesthesia, confirming patient identity, procedure, consent, site marking, allergies, and airway risks. Second, before the skin incision or the insertion of any device into a body cavity or orifice. This is the most well-known surgical timeout where the entire team pauses to confirm again the patient, procedure, site, implants needed, critical imaging availability, and any anticipated critical events. And third, before the patient leaves the procedural area or operating room, confirming things like the procedure performed, instrument and sponge counts are correct, specimens are labeled correctly, and any key concerns for recovery or post-operative care are reviewed. Crucial aspects for the success of this checklist approach include active, engaged, multidisciplinary participation from everyone on the team, surgeon, anesthesia provider, nurses, often the visual display of the checklist or other key safety tools for reference during the timeouts, and careful attention to overcoming hierarchies and fostering strong, respectful, team-based communication where anyone feels empowered to speak up if something seems wrong. An evolving area in surgical and procedural safety now is the use of simulation for team training and also video-based procedure review to continuously improve surgical technique, enhance perioperative team function and communication, and proactively identify latent threats or inefficiencies within the surgical workflow itself.
We focused a lot on inpatient hospital safety, which makes sense. But what about safety in outpatient settings? In clinics or even care delivered at home, where so much of pediatric care actually happens day to day? This seems like a less controlled environment with its own unique challenges.
You're absolutely right to highlight ambulatory safety, as a significant, probably the majority portion of pediatric care occurs outside the hospital walls. The safety events that have been best studied in this outpatient environment tend to be adverse drug events and medication dosing errors. There was a compelling study, for example, that carefully observed children receiving complex chemotherapy regimens at home. It found approximately 70 errors per 100 patients over the study period. Many of these errors were classified as serious or significant, and they often occurred because families were using inaccurate household measuring tools, like kitchen spoons, for liquid medications instead of precise dosing syringes provided. A highly effective solution identified in that study, and now more widely promoted, was the introduction of a health literacy-informed pictogram. Basically, clear, simple pictures showing exactly how to draw up and give the medication, which significantly reduced these dosing errors by providing instructions that were much easier for families to understand and follow accurately, regardless of their literacy level. Other significant ambulatory safety threats include things like delays in diagnosis or necessary treatment that are caused by mishandling or poor communication of important laboratory or imaging results between different providers, and critical failures in care coordination, especially when a child has complex needs and is seeing multiple specialists who may not be communicating effectively with each other or with the primary care provider.
And finally, we started by hinting at this, but let's talk explicitly now about occupational safety. We spent all this time talking about patient safety, but what about the safety and well-being of those incredible individuals providing the care? It seems easy to overlook their risks.
Yes, this is a growing and absolutely vital concern. As we mentioned briefly at the start, the provision of healthcare can actually be a dangerous profession, with overall injury rates that, quite surprisingly, surpass those of coal miners in some analyses. The magnitude of this challenge and the need for dedicated efforts to improve workplace safety for healthcare workers have gained considerable attention in recent years. Historically, certain types of injuries, like maybe a needle stick from a used needle or developing back strain from frequently lifting heavy patients, were often implicitly seen by nurses and physicians as just part of the job, an almost acceptable occupational hazard. However, a modern, mature safety culture must emphatically include employee safety alongside patient safety. They are interconnected. Health systems should have clear, easy-to-use, non-punitive mechanisms for employees to report their own injuries, near misses that could have caused injury, and any perceived threats to their safety, fostering the same psychological safety for staff reporting as we expect for patient safety event reporting.
So what kinds of things are being done to protect staff?
Well, focused improvement efforts include things like the widespread rollout and mandated use of safer needle systems with engineering controls to prevent sharps injuries, comprehensive education programs on safe patient handling techniques and processes, and ensuring easy access to and promoting the use of mechanical lifts for moving larger children or those with limited mobility to prevent musculoskeletal injuries, particularly back injuries, among staff. There's also particularly growing concern right now around violence and patient interaction injuries in healthcare settings. These often occur when caring for patients, including children, with acute psychiatric diseases or certain developmental disabilities who may become agitated or aggressive. These incidents are a growing source of both physical and psychological harm to clinicians. Solutions being actively pursued include educating clinicians on verbal de-escalation techniques, proactively engaging behavioral health specialists directly in bedside care planning and management for potentially challenging patients, and implementing standardized hospital-wide behavior response teams, sometimes called code grays, that can rapidly respond to and help manage acute behavioral escalations safely for both the patient and the staff. Protecting the healthcare workforce is not just an ethical imperative, it's also a critical factor in ensuring safe and high-quality patient care, because a burned-out, stressed, or injured staff simply cannot provide optimal care consistently.
That's a really powerful shift in focus, and it's absolutely right that we consider the whole ecosystem of care, including the caregivers. And now let's move to perhaps one of the most powerful and frankly maybe unexpected intersections in the future of safety, the relationship between safety and equity. The idea that there can be no quality without equity is a truly profound statement, isn't it?
It is indeed. The authors of the Landmark Institute of Medicine report Crossing the Quality Chasm, which really set the agenda for healthcare quality improvement over 2 decades ago, stated that healthcare should target 6 key aims for improvement. Care should be safe, effective, patient-centered, timely, efficient, and, importantly, equitable. And increasingly, we understand that these aims are not independent silos, they are deeply interconnected. We are perhaps just beginning as a field to critically examine the direct relationship between patient safety and health equity, and honestly, the emerging evidence is quite concerning. Existing evidence strongly suggests that there are significant disparities in safety outcomes for several specific groups of pediatric patients. This includes disparities observed for Black and Latino children, for children whose families do not primarily speak English and may face communication barriers, and for children who are covered by public insurance programs compared to private insurance. These are not just minor statistical variations. They appear to represent systemic inequities that lead to demonstrably unequal safety outcomes for vulnerable children.
Can you give some specific examples? What does the research show?
Sure. Let's look at some specific research findings highlighted in the source material. A large study looking at outcomes after pediatric surgery found that Black children had over 3 times the odds of dying in the post-operative period compared to white children, even after the researchers controlled for multiple variables like how sick the children were before surgery, pre-operative morbidity. That same study found Black children also had nearly 20% relatively greater odds of experiencing any postoperative complication and 7% higher odds of developing one of the defined serious adverse events. This points to a clear and alarming disparity in the safety of surgical care based on race. Another example, a systematic review looking at the evidence around pediatric appendicitis revealed that significant social, racial, and economic inequities exist across multiple aspects of care for this common condition. These included differences in the rate of misdiagnosis, the type of surgical approach used, less invasive laparoscopic versus more invasive open surgery, the length of the hospital stay, and even the rates of appendiceal perforation, which is a serious complication. These are core safety and quality outcomes where disparities clearly manifest along socioeconomic and racial lines. In the context of pediatric severe sepsis, which is a life-threatening condition, a large retrospective study found evidence of an increased odds of death for Black children compared to white children, particularly in hospitals located in the western and southern regions of the U.S. That study also found longer hospital length of stay for both Hispanic and Black children compared with white children suffering from sepsis. And yet another multi-center study focusing broadly on hospitalized children reported that hospitalized Latino children experience higher rates of adverse events overall compared to non-Latino white children, and also that publicly insured children experience higher rates of preventable adverse events compared to those who are privately insured, suggesting both racial, ethnic, and socioeconomic disparities in inpatient safety. These consistent findings across different conditions and settings really underline the imperative. The Institute for Healthcare Improvement's bold statement, "There can be no quality without equity," becomes profoundly clear and urgent. The field of pediatric patient safety is increasingly and necessarily focusing on health equity, not just as a separate goal, but as a critical and essential outcome measure of safety itself. We simply cannot claim to have truly safe healthcare if that safety isn't equitably distributed and experienced by all populations we serve. It's a foundational ethical and quality challenge for all future safety efforts.
That's a powerful and absolutely vital point to end on for that section. And finally, as we think about the future of safety, who better to partner with, who better to learn from than the patients and their families themselves? They are, after all, at the very heart of the care experience and have such a unique and valuable perspective.
Absolutely. This is another crucial area of current and rapidly growing research and practice innovation. What's fascinating here is that studies have shown that families often identify a wide number of errors and safety events, things that happen to them or their child, that clinicians themselves actually fail to report through the formal systems. They are often the first line of detection, possessing a unique, longitudinal perspective on the patient's condition and care journey that no single clinician, perhaps focused only on a specific shift or encounter, might have. But the true opportunity, I think, goes far beyond simply having families act as another source for reporting mistakes after they happen. The real potential lies in these early efforts to engage families more broadly and deeply to co-produce healthcare that is efficient, effective, and safe. This means genuinely involving them as partners in care planning, in shared decision making, and even inviting them to participate on quality improvement teams and hospital safety committees. This partnership is particularly important and maybe most obviously valuable for the growing population of children with complex chronic disease. For these children, family caregivers are often the primary observers and managers of their child's health day in and day out at home. This makes them absolutely critical in identifying subtle deviations from their child's baseline health status long before a clinician, seeing them only intermittently, might detect a problem brewing. Empowering and truly integrating families as active partners in the safety journey is a potentially transformative approach, leveraging their unique knowledge and commitment to enhance overall safety for everyone. Hashtag outro.
Wow, what an incredible, deep journey we've taken today. We've really journeyed through the intricate, often challenging, but ultimately, I think, hopeful world of patient safety in pediatric healthcare. We started by getting clear on the fundamental definitions of error and harm, then explored those sophisticated frameworks like Data Median and SEEPS, and that powerful visual, the Swiss cheese model, which really helps us visualize how systemic breakdowns can happen. We dove deep into the practical tools in the safety toolbox like incident reporting, the power of simulation for practice and finding latent threats, and the various methods of event analysis, from the deep dive of root cause analysis to the proactive approach of failure mode and effects analysis.
Yeah, and we really explored that critical, maybe less tangible, invisible architecture of safety, which is building a mature safety culture. We emphasized the importance of a just culture for balancing learning and accountability, and the absolutely critical role of psychological safety in empowering everyone on the team to speak up. We learned lessons from high reliability organizations and their 5 core tenets, seeing how industries like aviation achieve such exemplary safety records. We also saw concrete improvements in action, like that dramatic reduction in central line associated bloodstream infections through focused process improvement. And we looked ahead to the important frontiers of safety areas like recognizing clinical deterioration earlier, tackling the complexities of diagnostic errors with specific cognitive strategies, improving handoffs, managing alarm fatigue, and enhancing safety in surgical and ambulatory settings.
And crucially, we ended by looking at those vital emerging areas of safety research and improvement. The profound and necessary intersection of safe and equitable care, and the really transformative power of partnering authentically with patients and their families as co-producers of safety. What's really fascinating here, I think, is the takeaway that achieving safety isn't just about individual competence or trying harder. It's fundamentally about designing robust systems, fostering psychological safety, embracing new technologies responsibly, and creating a culture of constantly learning from every single event, whether it's a success or a failure.
Absolutely. It's that continuous learning and system improvement mindset.
So what does this all mean for you, our listener? What should you take away from this deep dive? Perhaps it's a renewed appreciation for the incredibly complex ecosystem of care that exists to protect our children and ensure their well-being. It's not simple. Or maybe it could be a challenge for you to consider. In a world that's striving for higher reliability and true equity in healthcare, how might your enhanced understanding of these dynamics, whether you engage with the system as a patient, a family member, a caregiver, or simply an engaged citizen, empower you to engage more effectively, to ask more informed questions, and ultimately to contribute in your own way to the ongoing, relentless pursuit of safer care for everyone?